So good afternoon, everyone. So angina was taken last week by Polo. So my first question is, what is angina? Yeah. Huh? What say? Chest pain. Okay. Huh?
Imbalance between oxygen demand and supply.
Yeah. So basically, heart needs to pump blood. So for that, oxygen and nutrients is required, so for the heart to work properly. So this is done through the coronary artery, and it can lead, so the symptoms are severe sudden crushing chest pain, and then heavy tightness, gripping and all. Pain radiation, it can radiate. Basically, typically the pain is in the center, and then it radiates to the jaw, to the arms, back, neck. So breathing difficulty is there, and sweating. So basically, what can block the coronary artery? So there are two things. One is your plaques and one is your spasm. So in plaques, you have stable and unstable angina. So stable angina, if you take rest, it can reduce. So but unstable angina, no, if you take rest also, it still continues, and you need medical help. So the patient needs to be hospitalized. And then your variant angina, it is an uncommon episode pattern, and occurs even in the case of rest, and due to decrease in the blood flow and myocardium from the spasm of the coronary artery. So although patients suffer from these type of angina, so it can be due to coronary atherosclerosis. So the angina attack aren't related to the physical activity or to any blood pressure and all. So response like nitroglycerin and calcium channel blockers, it can reduce variant angina. So now treatment. So treatment is very important. That is, it helps to balance the cardiac oxygen demand. So also affects in your BP, heart rate, and your contractility. So there are four classes of types of drugs. That is your beta blocker, calcium channel blocker, sodium channel blocker, and your organ nitrates. So basically, this is very, very important. So coming to your beta blockers, you will give propranolol. That is not a cardio-selective, but 80 to 120 mg twice daily. Then these two are your cardio-selective. That is a metoprolol 50 to 200 mg twice daily, atenolol 50 to 200 mg day. So other drugs are also there, like bisoprolol, so 10 mg, timolol 10 mg twice daily, and your carvedilol 3.125 to 25 mg. Then is your calcium channel blocker. So dihydropyridine and non-dihydropyridine. So in this, amlodipine 2.5 to 10 mg, and nifedipine 10 to 40 mg. So basically, amlodipine variant angina caused by the spontaneous coronary spasm. It is caused by spasm, so that time you can give. And extended release of oral formulation, that time nifedipine is given. So then is your verapamil. In your oral, 80 to 160 mg TID, and it can also be given in IV, so 5 to 10 mg, and diltiazem 30 to 90 mg. So verapamil, it has a great negative inotropic effect. So then amlodipine, but it is a weaker vasodilator. So contraindications in the patient with pre-existing depression, cardiovascular function, or AV conduction abnormalities. Then is your diltiazem. So slows AV conduction and decreases the rate of firing of the sinus nose pacemaker. So should be avoided in your heart failure patients, and can worsen due to its negative inotropic effect. Then is your sodium channel blocker. So it improves, basically it helps to improve the so it improves the oxygen supply and the demand equation, and it inhibits the late phase of sodium current. So for that, ranelazonin, is 375 mg twice daily, can be titrated to 500 mg twice daily, and further the dose can be increased based on the clinical response. And most important is your organic nitrates, that is your nitroglycerin. Basically there are many forms, so you can get in your sublingual, then oral capsule, topical ointments, and even transdermal patches, but basically it is preferred sublingual, and second is IV. So example, so there are examples like tablet, it is 0.5 to 1.2 mg for 10 to 30 minutes, and then isosorbide mononitrate oral 20 mg per 12 hour, and isosorbide dinitrate 0.18 to 0.3 ml for 3 to 5 minutes. So there are other things also. Basically patient education for nitroglycerin tablets or related to this class should be always taken, because there are certain ways the patient should take, like nitroglycerin tablet, so it should be taken, so the patient who is already having this kind, so should always keep the tablet with him or herself all the time, and take as soon as the chest pain starts. So while they're taking the tablet, they should sit or they should lie down, because it may cause fainting. So 3 doses are like it is sufficient, 3 doses separately after every 5 minutes, and if it's still not recovered, then you have to call for an emergency help. So addiction of this, so additional dose should not be given, 3 doses, that is sufficient, not more than that. And do not because it can lead to hypotension, then reflex tachycardia, and also may lead to myocardial infarction or heart attack. Then is your nitroglycerin ointments. So onset of action is 20 to 60 minutes, and it is applied on the chest, on the abdomen, or the upper arm. And this is an ointment you cannot be applying just with the finger. You should have a gloves, and then you should apply, because for prevention, so that it is prevented from absorption in the skin. And if you don't have a gloves, at least some plastic wrappers or covers, because for the safety. So apply morning, then after 6 hours. So a 12-hour drug free period at night is very much important. So at night 12-hour free period is very much important to, so that it is not tolerated. Avoid the tolerance of the drug. So remove the residual ointment before the next dose, gently cleaning it with soap and water, and patch it dry, and then after that you can apply the ointment back. Then is your nitroglycerin patch. So apply it to the clean hairless area in the upper arm, and remove the old patches before applying the new one. The old patches must be removed before sleep, and allow for 8 hours free period to replenish enzyme. So if no drug free period is there, then it develops tolerance. So of course for this, patient education is very important. So activities that can increase angina is your overexertion, emotional upset, and overeating. So basically they say for overeating, because okay, we'll come to that later. So higher the energy content, higher cholesterol or fatty content food, so if you take, your heart requires more energy to pump, to work properly, so it becomes harder for the heart to work. So there are areas related to vasodilation, like headache, flushing, then reflex tachycardia, orthostatic hypotension, and contraindications are also there related to drug allergies, which can lead to hypotension, severe anemia, then closed angle glaucoma. And never use PDES inhibitors, as it can increase the cyclic CGMP, which can lead to dangerous increase in your blood pressure. So thank you. Good afternoon, everyone. So today I will be taking the treatment guidelines for angina. Last week I've already taken a class on angina. So today is the treatment part. So I have taken these guidelines from European Society of Cardiology, and we'll start with first line therapy. So that is your sublingual nitroglycerin. So you will be getting in tablet form, that is 0.3 to 0.6 mg, and you can only take the 3 doses, that too like 5 minutes apart. And the patient who is taking this is asked to take the tablet with him or herself, and whenever they are taking this tablet they should sit or lie down, because after taking this they can feel dizziness. You can also get available in sustained release, that is 2.5 mg and 6.5 mg orally. Then there is your short acting nitrates also, which will act as your first line treatment, and long acting, that is your transdermal patches. So transdermal patches I've already explained in the last class. Then second is your beta blockers, so that can also be given as your first line treatment. Atenolol 50 to 200 mg OD, and metoprolol 50 to 200 mg BD. Then is your calcium channel blockers, that can also be given as your first line treatment, and there are two types, that is your dihydropyridines. In that you have amlodipine and nifedipine. So amlodipine is your 2.5 to 10 mg, and your nifedipine is your 10 to 40 mg. And in your non-dihydropyridines, you have your verapamil. You can get in both oral as well as IV. So oral, it is 80 to 160 mg TID, and your IV is 5 to 10 mg. And diltazem is your 30 to 90 mg. So this all comes in your first line therapy. Second line or third line, basically we can see only second line treatment guidelines. So ranolazolone, that is your, it comes as a sodium channel, so 375 mg twice daily. It can be titrated to 500 mg twice daily, and you can after 2 to 4 weeks, and you can have a dose of 750 mg also, based on the patient's criteria, clinical response. Then you have your ivabradine also, it can be used as your second line therapy, but use when beta blockers are contraindicated the patient. Then you can have your nicorandil, that is your second line treatment, referred to nitrates. So this also have contraindications, like if you contraindications, if I talk about nitrates. So first, talking about the side effects, it can be headache, flushing, hypotension, then posterior hypertension, reflex tachycardia, and contraindication with hypertrophic obstructive cardiomyopathy and PDE5 inhibitors like sildenafil. So beta blockers contraindication is reduced in heart rate, heart condition disorders, cardiogenic shock, and COPD. Then is your calcium channel blockers. So here also in your non-DHP you can have cardiogenic shock, then obstructive cardiomyopathy, and in your DHP you can have your low heart rate, heart rhythmic disorder, low BP. So you can also be giving antiplatelet therapy as well as statins in case of angina. So basically in stable, we know that if you take rest it can reduce, but like unstable angina, sometimes, most of the time, patient, if you give medication also, so it doesn't work, so patient needs to be hospitalized. And your variant angina, if you give at least nitrates, it will work. And non-pharmacotherapy, basically we will ask the patient to have a proper diet, basically of course reduce in salt intake, and avoid alcohol, avoid smoking. So diet is the main thing, as 20% is always workout and 80% is diet. So many people have food which has high cholesterol, fried, like there are so many things available. So there should be a certain control, and we can ask the patient to go for some sort of exercise, not heavy workouts, but at least go for walking, or which is suitable for the patient. So thank you.